Case 1. This ECG was recorded from a 60-year-old male who complained of indigestion and nausea after a heavy meal. When a period of rest and antacids have proved ineffective, his wife summoned his general practitioner who admitted him to hospital. Case 1. The ECG shows the raised ST segments of acute infarction in leads 2, 3 and AVF. There are pathological Q waves in leads 3 and AVF. The ST segments in leads I and AVL show a sagging appearance and the T waves are inverted in these leads. These represent reciprocal changes which make acute myocardial infarction more likely. The T wave is flat in V6. Comments. The ECG shows recent inferior infarction. In addition, the changes in the lateral leads are compatible with lateral ischemia. Symptoms that initially suggest a gastrointestinal cause are common in inferior infarction, and the ECG may help distinguish gastric from cardiac pain. The risk of cardiac arrest in acute infarction is greatest in the early stages, soon after the onset of symptoms. All personnel who care for these patients should be competent in ALS protocols. Case to the ECG was recorded from a 45-year-old male who developed retrosternal chest pain during an office meeting. A raised blood pressure had been discovered during a company medical 3 years previously, but he had not seen his GP about this and was not on any antihypertensive medication at the time of the chest pain. There are raised ST segments in leads 2, 3 and AVF, and in addition there are pathological Q waves in these leads. These findings demonstrate an acute inferior infarction. The R waves in leads V4, V5, and V6 appear smaller than one would expect, especially given the size of the R waves in other leads that face the left ventricle, 1 and AVL. The R wave in lead V4 is smaller than the R wave in both V3 and V5, providing clear evidence that there has been loss of R wave in the lateral precordial leads. The ST segments are morphologically abnormal and slightly raised in these lateral precordial leads. The ECG evidence suggests that infarction involves the lateral surface of the heart as well as the inferior surface. Comment. The inferior and lateral surface of the heart often share a common blood supply, and both areas may be affected during infarction. This patient was transferred to the cath lab for an urgent PCI. On angiography, this patient showed a large circumflex coronary artery that had become occluded. The patient received coronary stents. The ECG was recorded from a 69-year-old retired male who had consulted his GP because of increasing angina. There was a history of a heart attack 10 years previously. There are pathological Q waves in leads 2, 3 and AVF, diagnostic of old inferior infarction. In addition, there are sagging stent segments accompanied by T wave inversion in leads I and AVL. The stent segments are also sagging in leads V5 and V6, although the T waves remain upright in these leads. Comment. The ECG shows the changes of old inferior infarction. After 10 years, the Q waves remain as evidence of this. The T waves are now upright in the relevant leads. The sagging ST segments and T wave changes in the lateral leads are non-specific changes but suggest ischemia in this area. No other explanation for these changes is apparent from the ECG, and the presence of old infarction provides clear evidence for the presence of ischemic heart disease in this patient. Case 4. Egg. There are pathological Q waves in leads 2, 3 and AVF. This indicates previous inferior infarction. The height of the R waves in leads V4 and V5 is greater than 27 mm and the sum of the R wave in V5 and the depth of the S wave in lead 6 exceeds 35 mm. The ST segments are downwards sloping or depressed in the leads that face the left ventricle, I, AVL and V4, V5 and V6. These changes fulfill the criteria for the diagnosis of left ventricular hypertrophy. There is an isolated ventricular premature beat in the rhythm strip. Comment. Inferior infarction has taken place although the timing cannot be determined from this egg. The voltage changes are those of left ventricular hypertrophy that may have been caused by long-standing hypertension in this case. The cent T changes may be associated with the left ventricular hypertrophy present and cannot be used to diagnose ischemia. Myocardial infarction may be painless or accompanied by relatively little pain. This occurs more commonly in the elderly and in diabetics. The ECG was recorded from a 55-year-old man who had a 6-month history of retrosternal chest discomfort on exertion. His symptoms had been treated as gastroesophageal reflux, but the addition of antacids and proton pump inhibitors had not helped. After mowing the lawn, he experienced similar pain and attended his local GP. The GP found him to be sweaty and short of breath and made the provisional diagnosis of ACS. He received aspirin and nitrates, which partially relieved his symptoms. An ambulance was called where this ECG was recorded together with a BP of 90/45 in a patient who was pale, cold, sweaty and dyspneic with a low blood pressure 90/45. He was transferred urgently by ambulance to the cath lab for urgent PCI. A significant lesion in the left anterior descending artery was stented. He recovered well. Case 6. This shows the typical raised ST segments of acute anterolateral infarction in leads I, 2, AVL and precordial leads V2, V6. In addition, there is reciprocal ST depression in leads 3, AVF and AVR leads that record from the opposite side of the heart. There are pathological Q waves in leads 1, AVL and precordial leads V2, V3 and V4. There is extensive loss of R wave in the precordial leads. No R wave is seen at all until V5, and this is only a very small positive deflection as is the R wave in V6. Comment. The egg shows evidence of extensive anterolateral infarction, and the clinical findings are certainly compatible with left ventricular impairment resulting from this. Case 7. The ECG was recorded from a 68-year-old man who had recently had successful arterial surgery to relieve critical ischemia in his legs. He had also experienced a transient ischemic attack in the territory of the right middle cerebral artery 5 years previously. Case 7. The ECG shows the raised ST segments of acute myocardial infarction in leads 3 and AVF. There is apathological Q wave in lead 3. There are widespread scent segment changes, horizontal ST depression in leads V2, V3 and V4 and downsloping ST depression in leads I and AVL associated with T wave inversion. The R wave progression in the precordial leads is delayed. The R wave height in leads V2, V3 and V4 is the same in all leads and smaller than expected. There is no R wave of significant size in any of the precordial leads. Comment. The ECG shows evidence of acute inferior infarction with the typical raised ST segments of early infarction and a pathological Q wave. The ST segments in the precordial leads and the lateral leads I and AVL show reciprocal changes. These leads record from the opposite side of the heart to the area affected by the infarction, and the changes mirror those seen in the leads that record from the infarct area. The appearances of the ST segments should be carefully studied. The changes in leads V2, V3 and V4 show the horizontal depression often seen in acute ischemia. Leads I and AVL show downsloping ST segments. Compare this ECG with the previous example, which showed infarction and corresponding reciprocal changes in the opposite ventricular walls to this one. Old anterolateral infarction is also suggested by the loss of R wave in this ECG. Patients with coronary artery disease often have arterial disease elsewhere. Similarly, patients who present with symptoms of cerebrovascular disease or lower limb ischemia often have coronary artery disease in addition. Case 8. The ECG was recorded from a 60-year-old man attending an agricultural show who announced to a friend that he felt sick and then collapsed. Fortunately, these events were also witnessed and basic life support was started by members of the public. The continued BLS until an AED arrived from the first aid tent. He was promptly defibrillated with initial return of a perfusing rhythm and a blood pressure of 150/60. Following the achievement of ROSC, the patient regained consciousness. He was given aspirin and transferred urgently to the local cath lab for PCI, where a lesion in the left anterior descending artery was stemmed. Case 8. The ECG shows extensive scent elevation in leads I, AVL and V2, V6. There is reciprocal ST depression in leads 11, 3 and AVF. At this time there are no pathological Q waves. The pattern of R wave progression is abnormal. The R wave in V3 is smaller than the R waves in both adjacent leads, V2 and V4, suggesting infarction at some time, but it is impossible from this record alone to be sure whether this is recent or the result of previous ischemic damage. Comment. Sudden death is a common presentation of acute myocardial infarction and occurs most commonly at the onset of symptoms or shortly afterwards. Many victims have not suffered extensive myocardial damage but die because of an arrhythmia, typically ventricular fibrillation tachycardia. Provided basic life support and defibrillation are carried out promptly, an appreciable number of victims will survive. He survived to hospital discharge after an extensive stay. Sadly, on discharge he had a significant reduction in his ejection fraction on echo. Case 9-9. The ECG was recorded from a 72-year-old man who had been admitted to hospital following a myocardial infarction 3 weeks previously. On that occasion he had presented late, 12 hours after the onset of pain. At PCI, he had stents placed to lesions in the left anterior descending artery. He had a significant rise in HS troponin, several thousand. He was discharged to a cardiac rehabilitation program. Case 9. There are pathological Q waves in leads V2, V4, although there is also a Q wave in 6. This may be a normal finding. There is also significant loss of R wave in the precordial leads, no R wave being recorded until V5, further evidence of infarction in this area. Pli-ST segments have returned to the isoelectric line at this stage, although symmetrical T wave inversion is still present in the same leads. In the lateral leads, AVL, V6, the sent segments are downsloping and the T waves are inverted, but there are no pathological Q waves to indicate infarction. The sent T wave changes in these leads are compatible with ischemia in the area adjoining the infarction. Comment. The changes are those of recent anterior infarction. The late presentation of the patient probably contributed to the loss of myocardial muscle and subsequent development of Q waves. This patient had a significant loss of ejection fraction on echo. Case 10. The ECG was recorded from a 66-year-old woman 2 weeks after an anterior myocardial infarct. There was a history of previous myocardial infarction 4 years earlier. Case 10. There are pathological Q waves in leads 2, 3 and AVF signifying inferior infarction. In addition, there are pathological Q waves in leads V2, V4. Close inspection reveals a small R wave in V4 before the predominantly negative deflection, so this is an S wave, not a Q wave. There is loss of R wave in the precordial leads. No R wave appears until V4 and the deflections in both this and V5 are very small, providing additional evidence of infarction in this area. The ST segments in the anterior leads have not quite returned to the isoelectric line at this stage and T wave inversion is present. T wave inversion is also present in the lateral leads, AVL, V5 and V6. There are no Q waves in these leads, but there is loss of R wave in V5 and possibly V6, although it is not possible to be sure without a previous record for comparison with the other evidence of ischemic disease provided by the ECC. These lateral T wave changes almost certainly reflect ischemia or infarction in this territory. Comment. The changes in the anterior leads are those of a fairly recent infarction. The Q waves in the inferior leads date from her previous infarct 4 years earlier, and at this stage the T waves in the inferior leads have resumed their upright position. Case 11. The ECG was recorded from a 42-year-old man 48 hours after admission to the coronary care unit. Both his father and elder brother had suffered a myocardial infarction. He smoked 20 cigarettes a day. Case 11. There are pathological Q waves in leads V2 and V3. There is loss of R wave in the precordial leads. No R wave appears until V4 and this is smaller than the R wave in V5. It would normally be expected to be larger. The ST segments show the raised appearance typical of acute myocardial infarction in leads V2 and V3, and the T waves are becoming inverted in these leads at this stage. Established T wave inversion is present in leads I to AVL and precordial leads V4, V5, and V6. Comment. The ECG shows the changes of recent anterior infarction affecting the interventricular septum, as denoted by the changes in 6, V2 and V3, and adjacent left ventricle, as denoted by the changes in V4. Subsequent investigation showed that the left anterior descending coronary artery was occluded. Clinically, an ECG like this indicates a recent, but not in the last few hours, myocardial infarction. These patients should go for PCI, but there may be less urgency in doing so as compared to the hyper and acute changes of AMI seen in other cases. The patient should be managed as an ACS patient with aspirin, antiplatelet agents, and low molecular weight heparin according to local guidelines. The ECG was recorded from a 66-year-old man who was asymptomatic. The ECG was requested by the patient's general practitioner because of a history of infarction several years previously when the patient lived in a different part of the country. There were no details about the episode in his notes. Case 12. The ECG shows late appearance of R waves in the precordial leads. There is virtually no R wave in V3, which is the same height or even slightly smaller than the R wave in V2. The R wave in V4 is 14 mm, slightly smaller than the R wave in V5, 16 mm. The remainder of the ECG is normal. The apparent Q wave in 3 is in fact an S wave, as there is a small R wave recorded before this, the QRS complex being an RSR complex in this lead. The Q wave in lead AVF is not pathological, being less than 0.04 seconds and less than 25% of the height of the following R wave. Comment. The ECG does not provide definite evidence of previous infarction, the only clue to possible infarction being the pattern of R wave progression in the precordial leads. The ECG could be said to be compatible with old infarction, although not diagnostic. Case 14. The ECG was recorded from a 54-year-old man who had undergone coronary angioplasty to the left anterior descending coronary artery 6 months previously. He had experienced angina after an inferior infarct 8 months previously, and an exercise test had shown anterior ischemic changes at an early stage of the exercise protocol. His angina had recently recurred, and this ECG was recorded after an attack of unprovoked cardiac pain lasting half an hour had precipitated his admission to the emergency department. The most striking finding is the presence of downsloping or depressed scent segments in the anterolateral leads I to AVL and V3, V6. These changes are mirrored by scent elevation in AVR, which records the intracavity ECG. There are pathological Q waves in leads 3 and AVF from the previous infarction. Comment. Previous ECGs were available for comparison, and the changes were shown to be a new development and fortunately resolved without further ECG changes or significant rise in H-troponin. The scent-T changes seen here are very different to those in the previous examples recorded in the early stages of infarction. The appearances of the scent-T waves are not absolutely diagnostic of ischemia, and a similar appearances could be recorded in left ventricular hypertrophy, conduction disturbance, or in patients taking digoxin. However, in this case none of these factors apply, and the patient is known to have transient and developed acutely after an attack of ischemic chest pain. They provide valuable diagnostic evidence of myocardial ischemia in this case. Case 15. The ECG was recorded from a 50-year-old man with a 2-day history of retrosternal chest pain associated with a flu-like illness. The pain was aggravated by movement, coughing or taking deep breaths, but relieved by sitting forwards. There was a pericardial rub well heard at the cardiac apex. Case 15. There is elevation of the ST segments in leads I, 2, 3, AVF and 6, V6. Lead AVR shows ST depression. There are no pathological Q waves, and the pattern of R wave progression is normal. The PR interval is prolonged at 0.22 seconds. First degree AV block is present. Comment. The ECG shows the typical appearances of acute pericarditis. The morphology of the ST segment in pericarditis is often described as different to that seen in acute ischemia. The ST segments in pericarditis show the more concave upwards appearance seen in this case as opposed to the convex upwards appearance seen in early infarction. A more reliable sign, however, is the widespread distribution of T changes in pericarditis occurring in most ECG leads, compared to the changes of ischemia which are usually localized to leads recording from one area of the ventricle. The changes in pericarditis are thought to be due to inflammation of the myocardium in the area adjacent to the inflamed pericardium. This is a widespread process involving all the areas of myocardium covered by pericardium. Acute ischemia is a localized process, and the ST changes are restricted to the leads that record from the area deprived of oxygenated blood. In this ECG, the ST elevation is present in all leads except AVR and AVL. AVR is an intracavity lead and shows ST depression, a reciprocal change. Lead AVL is at right angles to the frontal plane axis and shows only a small QRS deflection, and there is no significant ST segment deviation. Small rises in serum troponin is common. Patients should have an echo performed to look for signs of pericardial effusion. Case 17. A 45-year-old man is brought to hospital by paramedics after being found by passers-by sat on the roadside. The paramedics can't obtain a coherent history and score his GCS as 13/15 E3V4M6. They perform an ECG and transport him to hospital. On arrival, the patient is agitated and non-compliant, has a blood pressure of 90/40ths, a GCS of 13 and 2 mm equal and reactive pupils. You elicit generalized abdominal tenderness with guarding. The patient denies chest pain. Case 17. A 45-year-old man is brought to hospital by paramedics after being found by passers-by sat on the roadside. The paramedics can't obtain a coherent history and score his GCS as 13/15 E3V4M6. They perform an ECG and transport him to hospital. On arrival, the patient is agitated and non-compliant, has a blood pressure of 90/40ths, a GCS of 13 and 2 mm equal and reactive pupils. You elicit generalized abdominal tenderness with guarding. The patient denies chest pain.